Phoebe Carter, and I'm a Urology Clinical Fellow working in Salisbury District General Hospital. I am going to be presenting our audit of our TULA service. So we're looking at the evaluation of a transurethral laser ablation service for superficial bladder cancer management in an outpatient setting in a UK DGH. So as an introduction, TURBT does remain the standard treatment for non-muscle invasive bladder cancer, and complication rates of this can vary widely in the literature from about 5% to over 26%. Now, this is quite an undertaking for particularly the frail and co-morbid patients who may not be fit for a general anaesthetic intervention. Transurethral laser ablation under local anaesthetic in an outpatient setting is a good option for this, particularly for this patient group, as it's safe and minimally invasive, and again, it kind of avoids the need to have a general anaesthetic high-risk procedure, and also patients can continue on their anticoagulation treatment, so reduces the risk of them developing a stroke or some kind of clot elsewhere from being off their anticoagulation for a period of time during a perioperative period. So the objective of our audit was to evaluate the safety and efficacy of an outpatient TULA service in a UK DGH. So in terms of our methods, this was a retrospective review of 50 consecutive patients who underwent TULA in 2023. Our local TULA service was set up a year before in 2022, so this was at the point when the service was up and running and working well. Standards for our audit were taken from a mixture of the GERFT guidance and NICE guidance for implementing a local TULA service. Data was collected from electronic patient records, included demographics of patients, clinical documentation around the time of the TULA and indication for this, tumour histology at the original diagnosis of bladder TCC, the indication for them having TULA, any post-procedure complications, and recurrence rates for up to 2 years. So in terms of the patient group, the mean patient age in this study was 80.66 with a range of 49 to 98. So this highlights the population that we're serving and how elderly they are. Most patients, 60%, had low-grade G2 PTA as their original histological diagnosis. 16% had no previous bladder cancer history, and so this was their primary procedure to get histology. During the follow-up period of 2 years, 40% of patients went on to have further TULA treatment, and 16% of the patients in this study were booked directly to TULA treatment ongoing, as they had recurrent superficial bladder TCC, and that this was just being managed in the outpatient setting rather than putting them through a general anaesthetic because they weren't fit enough for this. Interestingly, 14% of patients died within the 2-year period, but only one of these deaths was attributable to metastatic bladder cancer. And again, this highlights just what a frail and comorbid group that we've been treating. In terms of the indication for TULA, 68%, the majority was for a suspicious for recurrence, essentially. Red patches were the next most common at 18%. 12% of patients had a new tumour, and these patients with a very frail and comorbid who may not be fit enough for a GA, and 2% of patients had field change. Our complication rate was very good. We had a 2% rate of urinary tract infection within a 2-week period, and a 2% complication rate of hematuria at 1 month. We didn't have any other instances of the urinary retention, perforation at 2 weeks, ongoing pain, hydronephrosis at 6 months on repeat imaging, or any readmissions within a month, which was all very reassuring. In terms of our recurrence rates, you can see that at 6 months it was 28.3%, it went up to 42.9% at the year, and 54.1% after a 2-year period. So the recurrence rates were increasing over that time. But as I mentioned, quite a large proportion of patients needed recurrent treatment as they weren't fit for any GA procedures. So we were still managing them in the outpatient setting and potentially avoiding admissions with hematuria as a result of not being able to have any treatment for their recurrent bladder tumours. In terms of what the literature suggests about non-muscle invasive bladder cancer 5-year recurrence rate, this can be anywhere between 31 to 78%. So we may well be kind of within that area, which is also reassuring. So to conclude, outpatient TULA is a safe and well-tolerated treatment option for selected patients with non-muscle invasive bladder cancer, and is a particularly favourable option for the frail and comorbid patient group. There do need to be considerations and challenges to be considered when setting up a TULA service, including having an experienced clinician, and patient factors, including their ability to kind of tolerate a local anaesthetic procedure and cooperate, and particularly whereabouts in the bladder the lesions may be, and particularly over the trigone can be more painful for patients. In terms of logistics, there needs to be a dedicated laser safe area in an outpatient setting, and appropriate staff trained to be involved in these lists. It also makes sense to have these all as a list running all at the same time due to the need for specialist equipment. As already mentioned, it offers an effective alternative to GA procedures for the higher risk patient group, and it also has a low complication rate, making it quite safe for these elderly, frail patients, and also potentially prevents them having a complication or needing an admission because of a bladder tumour that we've not been able to treat. So that is a positive. In terms of moving forward, we aim to continue to audit our TULA service and look at our red patch pathway in the future to see what our pickup rate is of any recurrence or abnormality, and whether we can try and optimise this any further. Thank you very much.